Our next presentation will be Reproductive and Family Building Considerations for Female Patients with Anorectal and Urogenital Malformations. It will be presented by Dr. Reppucci from Children's Hospital, Colorado.
As survival for patients with anorectal malformations has improved, there's been increased focus on their long-term outcomes. Little, however, is known about the fertility and pregnancy outcomes in patients with these malformations. Of particular interest are those patients with long common channel cloacas and cloacal exstrophy, as they may face a variety of unique fertility challenges. We therefore sought to report the fertility and pregnancy outcomes of our patients with anorectal malformations and performed a retrospective review of female patients who reported pregnancy or having children from our colorectal database, which has been prospectively maintained since 1980. We collected demographic, anatomic, operative, and self-reported fertility and obstetrical data for each patient. There were 37 patients who reported pregnancy or having children, and the distribution of their anatomy is displayed here in the chart. Of note, 7 women have long common channel cloacas, defined as greater than 3 centimeters in length, and 1 woman has cloacal exstrophy. These 37 women reported 59 pregnancies in total, of which 33 or 55% were known to be via spontaneous conception. 2 women with cloaca reported successful in vitro fertilization pregnancies. Another woman with a cloaca reported twin delivery via surrogacy. It is unknown if she used her own eggs or donor eggs. Additionally, 2 women with cloaca reported adopting children after unsuccessful in vitro fertilization attempts. No patients in our cohort who underwent bowel partial vaginal replacement became pregnant. There are additionally no reported cases of viable pregnancy in women who underwent this form of reconstruction in the literature, with only 1 reported case of nectopic pregnancy. This is important because animal studies have shown that sperm has decreased vitality after contact with bowel mucosa, which would impair these patients' ability to conceive. Based on the experiences of our patients, we identified various challenges that they may face during reproduction or pregnancy. Women with anorectal malformations are capable of spontaneous pregnancy, but those with more complex anatomy may have impaired fertility. For those who require assisted reproductive treatments, standard oocyte retrieval may be challenging, as transabdominal approaches may not be possible in a reconstructed cloaca, and transabdominal or laparoscopic retrieval of eggs may be contraindicated due to their surgical anatomy. This leaves 2 potential options for these patients. The first is oophoropexy, which would allow for eventual transabdominal retrieval of eggs. However, this would have to occur in infancy during the patient's index operation, and it is unknown if this would last until childbearing age or create complications. The other option would be ovarian preservation, which similarly would have to occur during the patient's index operation, and we know from the surgical oncology literature that there's little data on successful pregnancy following cryopreservation in prepubertal females. These women may also have multiple associated anomalies, including cardiac conditions. 1 woman in our series had a double outlet ventricle, which prevented her from valsalvaing and contraindicated vaginal delivery. For those with more complex cardiac conditions, cardiac anesthesia may be required for cesarean delivery, and the appropriate planning is indicated. Up to 30% of these women may have tethered cord, which prevents neuraxial anesthesia options such as spinal and epidural, and limits their only anesthesia option to general anesthesia. It's important to educate these women to manage their expectations, as well as to alert the anesthesia team prior to delivery. For patients with rectoperineal or rectovestibular fistulas, we recommend assessment of perineal body adequacy prior to offering them a trial of vaginal delivery. 2 women in our series with rectovestibular fistulas sustained 4th-degree perineal tears during vaginal delivery and required redo PSARPs after birth of their children. For those with more complex reconstructions, we recommend cesarean delivery with the assistance of a colorectal surgeon or a urologist to decrease operative morbidity. In conclusion, there are various reproductive concerns for those with complex anorectal malformations, including that their ability to conceive naturally may be impaired, and standard-assisted reproductive techniques may be limited by their anatomy. Further research is indicated to examine their true fertility potential, as well as the need and options for fertility preservation. In the interim, we emphasize that early fertility counseling should be offered to patients and parents of patients with complex anorectal malformations. I would like to thank my co-authors on this study, as well as the members of the International Center for Colorectal and Urogenital Care for their assistance and support. Thank you, and I will take any questions.
That was great. Kathy Van Leeuwen from Phoenix. So I love this database. Thank you, Dr. Pena and Dr. Bischoff, for collecting this data for so many years. It's so great to see those numbers of people actually conceiving. I got to do one in January, a C-section on a cloaca, complex cloaca. I was sure she would never have a baby, and that baby came out crying and screaming, and it was amazing. So 2 questions. You mentioned that the patients who had a bowel conduit had some more difficulty. Are you suggesting maybe we want to hold off on creating vaginas using bowel in the newborn period? And then the second question is, you mentioned maybe ovarian preservation during the index procedure, but it seems like it could easily be done later in those patients. Even though they've had complex reconstructions, there's a lot of centers now doing laparoscopic approaches to cloaca, and we're finding it's easier to get into the belly than we thought. So how about ovarian preservation for later in life? Thank you so much.
Thank you for your questions. So for your first question about using bowel for reconstruction of the vagina, we still recommend this as a form of reconstruction, even though it may impact the fertility. As far as we know, there are no reported cases. That doesn't necessarily mean there are none. And the most important thing for these patients is that they undergo reconstruction so that we can prevent any of the sequelae from the cloaca, just with it in mind that they may have difficulty with fertility in the future. In terms of the ovarian preservation, if there is difficulty in accessing the ovaries in the future, it would be required that this would have to happen during their index operation. But if we are now finding that redo operations or entering the abdomen is easier in these patients, obviously for their fertility outcomes, it would be better to harvest eggs after puberty.
Hi, Laura Tiusaba from Children's National. Thank you for an excellent presentation. I was curious about when you think the right time to start counseling should be, since there's such a big gap between when they move on from pediatric surgery. When do you think the best time to start that would be?
So at this point, usually when the parents, obviously they're very overwhelmed by the multiple problems that their children may face. Earlier is better. A lot of this is just self-reported data, so we don't know the true fertility potential of these patients, but we think that counseling parents early allows them to have the appropriate planning, as well as if we need to start involving our obstetrical gynecology and fertility specialist colleagues early, so that when these patients reach childbearing age or want to pursue pregnancy, they have all the options available to them, and we're not realizing it's too late for them to pursue options.
Thank you.
Thank you.